Tonight, we're going to kind of do an overview of multiple sclerosis, but we're also going to go way back in time and talk about sort of the history of MS and look maybe back and see if we can identify who we think may have been the first person ever described with multiple sclerosis. And again, do an overview. And I'm going to leave time at the end for questions. And what I'd like to try to do is each time we have one of these meetings, try to focus your questions on what we talked about that evening. Obviously, there's a lot of stuff going on in the MS world, but we're going to go through in the next few months symptom management, whether it's fatigue, spasticity, looking at what's available right now to alter the course of multiple sclerosis, and then moving into what's available in the future. I'd like to say thank you to the MS Foundation for helping put this together. We have our wonderful video crew here with Chris, and so these lectures will be on their website for future use. So if you do miss one in the series, you can always go and look them up also. I'd also like Derek did, thank our sponsors this evening, Teva Neuroscience, Biogen IDEC, Mallinckrodt, and Accorda for helping us put this together. So I'm going to see if my technology works here. It does. So what is multiple sclerosis? MS is an autoimmune condition. It's your immune system picking on something that it shouldn't be picking on. It's complicated. If you ever go to medical talks and they put a slide up with an overview of how we think the immune system works in multiple sclerosis, your head will start spinning. And every year that slide gets more and more complicated. That's both a blessing and a challenge. The more we know about the immune system, the more we think we can attack different areas and hopefully stop or maybe reverse the effects of multiple sclerosis. But sometimes it gets intimidating. The human immune system has sometimes been compared to a never-ending onion. You keep peeling back layer upon layer upon layer, and it just gets more and more complicated. Does anyone know Lidwina of Hygiene? Nobody, no friends here of Lidwina. Lidwina, in the picture to your left, can you tell what she's got on her feet? She's got ice skates, really old-fashioned ice skates. Lidwina was a young woman in that carving. She's probably 14 or 15 years of age, and she lives in Holland, and she was ice skating. That was one of their forms of recreation there. What started happening is Lidwina would skate for a little while, and then she would get a little overheated, and her legs would give out, and she'd fall down. And then she started having attacks of visual loss, and then she started having other attacks. Lidwina was probably the first well-described case of multiple sclerosis that we know of. If you are a Catholic, she is a patron saint. She is the Dutch patron saint of ice skaters. She is well described. She was the reason that she was put into the sainthood is she was said to have not consumed any food or water for the last 10 years of her life, and it was felt to be miraculous that she continued living. And she would have people visit from all over Europe and come to seek her counsel and her religious advice. And so that's her in her latter years with an angel over her. So she is the Dutch patron saint of ice skaters, and she is probably the first well-described case of MS. So now we fast forward 400 years. I don't speak much French. I think that's Augustus d'Este. He was the illegitimate grandson of King George III. So he was a prince. He was a very well-described gentleman with MS, and he was well-described because he wrote a whole lot. He kept diaries, and you probably can't read down on the right-hand side, but these are some of the entries. He made daily entries and described his symptoms. People didn't know what was wrong with him at that time, but he described relapsing remitting multiple sclerosis really well. He would have attacks of weakness in his legs. He had optic neuritis, and again, did a really good job of writing about all that. So we're still in France now. We're just a few years later. Now we're in 1868. This guy is really important to neurologists, Jean Charcot. Jean Charcot is the father of modern neurology. This painting in real life is probably bigger than it projects up on the screen. It's a huge mural, and it hangs in a hospital in Paris, in the Hospital Salpêtrière Museum. So this is Dr. Charcot, and he wrote a lot about multiple sclerosis, and he used the French term at the bottom there, la sclérose on plaque. And so the lady that he's examining there, he would go around and do these very detailed lectures, and he would have a live patient and show these folks what was going on. In the audience there are a lot of really important people. We'll go over some of their names later. One of the guys that's in the audience, he may be the one scratching his head back there, is Sigmund Freud. So how many of you thought Sigmund Freud was a psychiatrist? He was, but he was a neurologist before he was a psychiatrist. And what was common back then, when you wanted to learn something, you went to one of these really well-known professors like Dr. Charcot, and Dr. Charcot would assign you a job. And so what he assigned to Sigmund Freud, he said, I want you to go into these children's hospitals. We have kids who have something. They don't walk well. Sometimes they don't walk at all. They have a lot of tightness in their muscles. He goes, I want you to categorize and interview these kids, talk to their parents, and let's figure out what's going on. What those kids had was cerebral palsy. And so a lot of the terms that we use in cerebral palsy were from Sigmund Freud, but he doesn't get credit for that. He gets more notoriety for what he did in psychiatry. The interesting thing about the young lady there that Dr. Charcot is examining is her name was Blanche, and she was his favorite patient. She was also his favorite mistress. And it turns out Blanche didn't have anything wrong with her. She was a really good actress. And so he could describe a neurological condition and she could mimic it and demonstrate it for people. And he actually found that easier to do than getting someone with the actual condition. So she was a really good patient actor. So now we move on. Yes, sir.
What were the medications in those days?
So there were no medications then. Absolutely nothing. Yeah, and we'll come back to that thought in a second. So, yes. Steroids did not exist. So synthetic steroids really didn't exist to treat multiple sclerosis relapses until the 1970s and 80s. Yep. So now we fast forward to this guy. So you'll notice a trend here. So Dr. Charcot has no facial hair. He was kind of a rebel. I don't know if I would have trusted him. I don't trust men without facial hair. Sorry. But you'll see most everybody else has facial hair. And from then on, there was a rule. If you were a neurologist, you had to have facial hair. I don't know about female neurologists. I guess you could too. So in 1878, this guy Louis Ranvier discovered myelin. So that term Ranvier is something we still use today. When you look at how nerve fibers work in the brain and spinal cord, there are little gaps between the myelin where there is no myelin. Those are called nodes of Ranvier. And we'll come back to that and show you some pictures of it. Now we get into a whole bunch of other players. So this guy up here, now that guy's got the coolest mustache ever. Dr. Lermite. So what did Dr. Lermite describe? So we actually use that term now. Have any of you ever bent your neck forward and got funny electric shock-like sensations into your arms or legs? That's called Lermite's sign. And so Lermite knew that if you bent your neck forward and you got funny sensations in your arms and legs, that there was a really high chance that you had multiple sclerosis. There are a handful of other things that can do that, but multiple sclerosis is the most common one. So we use that term Lermite's sign to this day. This guy here in the middle, Dr. Uthoff. So how many of you have symptoms that get worse if you get overheated? So that's a common thing. 70% of people with MS have heat sensitivity. And so we call that Uthoff's phenomenon. But it was more than just a symptom. Dr. Uthoff actually used that as a diagnostic test. So there were no MRIs back in the 1800s. So what Dr. Uthoff would do if he suspected you of having multiple sclerosis is he'd put you in a tub of really hot water and he would see if something got worse. And what he was really looking for is he was trying to see if your vision got worse. And that was his diagnostic test of that time. And we still use that term, Uthoff's phenomenon. If you do something and you get overheated and you have a symptom that gets worse, that's whose name is stuck on that. The guy down here in the bottom, Dr. Babinski. So what's he famous for? So if you go to the neurologist and we torture you by scratching the bottom of your foot with a sharp object and you want to smack us, that's called a Babinski reflex. Normally, if you scratch the bottom of someone's foot and they don't have any problems in the brain or spinal cord, their big toe goes down If we scratch the bottom of your foot and you have a problem in the brain or spinal cord, like multiple sclerosis, your toe may point up. And that's called a Babinski reflex. It's not specific to multiple sclerosis. You can see it in cerebral palsy and stroke and spinal cord injuries, but he was the German neurologist who first described that. Right after he did that, there was a whole flood of other neurologists who said, "Ooh, wait, I can do other things and make your toe go up. I can run my knuckles down your shin and make your toe go up." And that's called an Oppenheim reflex. I can scratch something sharp along the side of your foot, not the bottom of your foot, and make your toe go up. That's called a Bing reflex. So there was this big race for everyone to get their name on a reflex, and so there are a lot of different ways for us to look for that. Poor Dr. Dawson. That is not Dr. Dawson's brain up there on the top right-hand corner. I searched the internet wide and low and could not find a picture of Dr. Dawson. But what Dr. Dawson was famous for, those white spots that you see in that brain MRI, so you can see the dark underneath it, that's the spinal fluid. That's your brain's plumbing system. Can you see how it looks like the white spots are kind of projecting off of that? And if you use your imagination, you could say, well, they kind of look like little fingers projecting off of that. That was Dr. Dawson who first described that. And so when we look at your MRI, if we see white spots in your brain that look like little fingers, we call them Dawson's fingers. And so that was from Dr. Dawson in 1918. Obviously, we didn't have MRIs in 1918. He was looking at real brains of people with multiple sclerosis. And then the guy down at the bottom, Dr. Ortega, he was the first person to discover where myelin came from. He discovered that the oligodendrocyte cells in the brain and spinal cord actually make the myelin. 1946, the lady up in the top there, that's Sylvia Lowry. That's her brother sitting with her. Her brother had multiple sclerosis. There was not a whole lot known about multiple sclerosis, and she was very frustrated about the lack of treatment options. And so she posted a classified ad in the New York Times magazine and said, "Anybody who has MS or anybody who knows anything about it, would you give me a phone call?" And she was just desperate for information. And based upon that desperation, she went on to found the National Multiple Sclerosis Society in 1946. 1986, the MS Foundation. So our sponsors for this evening. It's been my pleasure to work with the MS Foundation over the years. Great group of people. I would say they're kind of like the little engine that could. You know, they do a lot with very little. The entire organization for the MS Foundation is about the same size as one state chapter for the National MS Society, but they get a lot done nationally with a very dedicated staff of talented people. So now we're getting to what you're talking about, the treatment options. So if we're here in 1992 having this discussion, the treatment option part of the discussion is very, very short because there were no FDA-approved treatment options. That's not to say that people didn't try things. So steroids were obviously around in 1992. Chemotherapeutic agents were around in 1992, and all of those things were tried. Before we got to the first FDA-approved treatment in 1993, beta-seron, there was a lot of trial and error. A lot of other things were tested. So when we talk about beta interferons for use in multiple sclerosis, beta interferons are molecules that we have naturally in our own body. They're chemical messengers that let white blood cells talk to one another. Well, there are other types of interferons in our body. There's something called gamma interferon, and gamma interferon was tested first in multiple sclerosis before beta interferons were. Gamma interferon was not a good thing for multiple sclerosis. It made MS worse. And to add a little injury to insult, it not only made MS worse, if you were in the trials with gamma interferon, they gave it by a spinal tap. So they put it into your spinal fluid once a week. So you went into your doctor, they did a spinal tap once a week, and they gave you something that made you really sick. So that was a study that you really probably wanted to be in the placebo group with. But then they discovered the beta interferons showed that those do work in MS. As we're here this evening, we have 13 FDA-approved treatments for MS. 1998 was a big year. So in 1998, we had Avonex, we had beta-seron, we had Rebif, and we had Copaxone. But we weren't using those drugs very aggressively. A lot of doctors and other healthcare providers, if you had MS, they kind of took a wait-and-see attitude. The thought was, well, you've had a couple of attacks, let's just see what happens. And then we might consider starting one of these drugs. Well, then a guy at Cleveland Clinic, Bruce Trapp, showed that there was nerve fiber damage occurring very early in multiple sclerosis. We knew that MS would damage the myelin, the insulation of the nerve fibers, but we really didn't talk much about it actually cutting the wiring. And if you cut the wire, if you transect the nerve fiber, that's permanent damage. So right after Dr. Trapp at Cleveland Clinic showed that, the National MS Society issued their first consensus statement on starting treatment early with MS. And really, ever since that time, the move has been towards getting people diagnosed more quickly and getting people on treatment as quickly as possible. So why did I say sacre bleu? I think that's French for good grief or holy cow. This is Dr. Charcot. He's a little angry about that. So here we are giving credit to Dr. Trapp for this discovery, when actually in reality, if you go back to 1868 and if you could read French, Dr. Charcot actually said multiple sclerosis cuts nerve fibers, and somehow over the next 150 years that just got lost in translation. So if we had done a better job with our medical history, we would have probably been more aggressive in managing multiple sclerosis from day one in 1993 when the first treatment came out. So we talked about Dr. Ranvier, these little yellow gaps here, those are the nodes of Ranvier. So this is a normal myelinated axon or nerve fiber in the brain or spinal cord. And what should happen is when you want to get information from point A to point B, so if you want your brain to tell your right leg to move, or you want your left foot to tell your brain, I just stepped on a nail, you might want to move the foot, the information has to travel up and down these nerve fibers. And what normally happens is the electrical potential will jump from yellow spot to yellow spot. It's a very fast, very efficient way to get information from point A to point B. Those are those nodes of Ranvier again. Well, now MS comes along, and through those immune attacks, it starts damaging that myelin. And because of it stripping away that insulation, now that electrical potential can't jump from gap to gap to gap. So now we've got a problem. We can't get information efficiently from point A to point B. And again, this was that 1998, or if you want to give the right guy credit, the 1868 paper that showed the nerve fibers actually get cut themselves. So if we go back and we say, well, what if the nerve fiber isn't cut? So if you strip the insulation, the myelin away from the nerve fiber, can that nerve fiber still work? It can. And this is why we would like to see the nerve fibers not cut, because even as long as that nerve fiber is still intact, there are a couple of different ways that you can still get information up and down that nerve fiber. Ideally, your body would make new myelin, and that does happen. One of the mysteries is why don't we do it as much as we would like to? We don't know that. That's a whole big area of neural repair research, is how can we get the body to repair the myelin more effectively itself? When we hear about people getting better on one of our long-term medications, any of the disease-modifying therapies, and it does happen. You'll hear people say, well, I started drug X and I did better than stabilized. I actually improved. Do we think that those drugs are actually repairing damage directly? Probably not. What's probably happening is that you're stopping the underlying attack in a way that you let the body repair naturally on its own. So there is the potential for myelin repair. What if you don't repair that myelin? Well, you can still reestablish that nerve conduction, that electrical information, even if you don't make new myelin. That naked nerve fiber can conduct an electrical action potential. What it does is it takes something called sodium channels that were all bunched up at that node of Ranvier, and it spreads them out along that naked nerve fiber. And that's a plan B for making the nerve fiber work again. The problem with that way of reestablishing nerve conduction is you've got this naked nerve fiber with these sodium channels kind of spread out all along it like a Band-Aid. Now if you use that naked nerve fiber again and again and again, like with prolonged exercise or walking, or if you raise your core body temperature, Or if you do both of those things at the same time, so you go out and you try to do some sort of exercise and it's 95 degrees outside, that area of Band-Aid, that naked nerve fiber, may stop working. It's called conduction block, and it's frustrating. You've hit the wall, you can't do any more of that activity, and you've got to wait a while. A while might mean an hour, a while might mean sleeping and resting overnight until that battery is recharged. One of the important things to know is if you drain the battery and you do an activity or you overheat and you make your symptoms act up, you're not causing any permanent damage. And we just can't get that message through enough. So we don't want people with MS to avoid exercise and avoid activity. It's a balance. We want people to be active. We want you to be as fit as you can be. But on the other hand, we know that people hit a wall sometimes. And ideally, what your body would do is it would give you some little clue. Yes, ma'am.
Does that include dehydration?
So dehydration, if you will tend to raise your core body temperature. So usually if you exercise enough or you go outside and it's hot enough that you dehydrate, you've probably raised your core body temperature. There are a lot of other reasons we don't want you to get dehydrated. If people get dehydrated, their constipation tends to get worse, and you're actually more at risk for bladder infections if you're dehydrated. A lot of people, and this is a little sidetrack here. No, I like sidetracks. Just reel me back in a second. The other problem that we see with dehydration is a lot of people try to manage their bladder symptoms. If you've got a lot of urinary urgency and frequency, you're having to go every 30 minutes, people say, well, I'm just not going to drink a lot of water. Well, the problem is if you dehydrate yourself and you concentrate the urine in the bladder, concentrated urine is a bladder irritant. You can actually, ironically, make your urinary frequency and urgency worse by cutting back on fluids. So we would rather you drink lots and let us try to find other ways to manage the bladder symptoms. Yep. Yes, sir.
How do you handle the heat? You know, I get this burning, a lot of burning, sometimes extreme, but it doesn't last long, but it's burning a lot.
Yeah, so how do we handle the heat? And then also I had a question about burning. So obviously we live in the South. It's hot here. The summer was hot, and 70% of people, again, with MS do have heat sensitivity. So some people just stay indoors when it's hot. We would like to give people more options to be outside. So we look at cooling strategies. There are lots of different manufacturers of cooling vests out there. The Multiple Sclerosis Foundation has a cooling vest program. If you go on their website, they have a scholarship program for cooling vests. So if you don't have a cooling vest and you're heat sensitive, it might give you the option, if you wanted to go to your kid or grandkid's baseball game or soccer game, and you thought, I can't do that, it's too hot outside. The cooling vest might let you do it. There are, again, lots of different versions of cooling vests out there. Cool wraps for your neck are something that work for some people. And then the other thing that we recommend is staying hydrated, but also the consistency of what you drink. If you make something that has the consistency of a Slurpee or a slushie, so it's kind of icy water, it will help drop your core body temperature a little bit more effectively. We have had it pointed out to us that pina coladas and margaritas do have that consistency, but you have to make that decision yourself. Yes, ma'am.
Sir, he wasn't talking about heat.
He was talking about the burning.
The burning sensation within the multiple sclerosis itself.
So his question was on a burning sensation actually in the legs. So the cruel thing about altered sensation in multiple sclerosis is it's never plain old boring numbness. Most people have altered sensation, and when we say it's altered, it's usually not altered in a good way. It'd be nice if you had altered sensation and it felt like someone was giving you a back rub. So well, that would be a good altered sensation. Unfortunately, never happens. Usually the least obnoxious form of an altered sensation is people will say, well, it feels like it's tingling, or there's bugs crawling, or there's cold water running when there's not. Unfortunately, it may actually go to the burning hypersensitivity. So a lot of people with MS will describe a hypersensitive sunburn sensation. Even light clothing touching their legs is just driving them nuts. The good news is that there are lots of treatment options for that. Most of the medications that we use to treat that sort of unpleasant altered sensation, you can put into one of two camps. There are antidepressants that we use to treat that altered sensation. Even if your mood is fine, because of the way those drugs work chemically in the brain, they may be very useful for pain management. And then there are anticonvulsants or seizure medicines that we use for pain management. And the way that those, again, even if you don't have a seizure disorder, we can use those drugs to help tone down that pain. The good news is you've got lots of treatment options for that sort of burning discomfort. The challenge is you got lots of treatment options, and unfortunately sometimes there's trial and error into finding the right magic bullet for an individual. But good question. Yeah.
If that happened like that, I don't know if I understood that okay or not. If that happened, if you let it be without any medication, is that possible that the body rebuild itself, or the immune system, myelin system, rebuild itself again, that to repair those parts of the damage,
So,
the nervous system?
so her question is, how much repair does your body do on its own if we don't do anything? The body does repair in some people. Again, the challenge for us is it doesn't always do a perfect job. In some people, we think it may not do much at all. I mean, you're experts on multiple sclerosis, that one person's story with their MS may be completely different from someone else's story. We see individuals who have very, very mild forms of MS, and at age 85, they've not been on any treatment for their MS, and they're really doing okay. We see people who have lots of difficulty very early in the course of their multiple sclerosis. And I think what distinguishes those groups of people, putting treatments aside, is I think some people's immune systems can put the fire out a little more quickly and stop inflammation. I think some people's bodies do generate repair more effectively, and other people don't put the fire out and they don't generate much repair. And we don't know what distinguishes those two groups of people. Obviously, we'd like to take what's good in these people and say, okay, how do we give that to this person? And again, it's an area of a lot of research. I think the next wave of MS developments will hopefully be in the arena of neural repair. I would say waiting and letting your body, doing nothing for your MS, unless you're one of those blessed people with very, very mild MS, doing nothing is a bad option. And unfortunately, we're not smart enough in the medical community yet to sit with that newly diagnosed individual and say, you know what, you're that person who's going to follow the mild course. I don't think you need to be on treatment. We can make some educated guesses, but big emphasis on guess. I mean, I can tell the 90-year-old looking backwards, I have a hard time telling the 20-year-old, you don't need to be on treatment. Yep. So this is what those cut nerve fibers look like under a microscope. And on the A on the left, this is a new MS lesion. On the right is an older MS lesion. And what those little green bubbles are, those are called retraction bulbs. This, after you cut a nerve fiber, it sometimes draws back on itself and makes that little bubble. And so you can see in the newer lesion, there are more of those retraction bulbs than there are in the older lesion. So why would that be? Why would there be more of these areas of cut nerve fiber in a new lesion versus an old lesion? Have the nerve fibers hooked back up and repaired themselves in the old lesion and made those retraction bulbs go away? Unfortunately not. The reason there are fewer retraction bulbs in that old lesion is because the neuron, the cell that nerve fiber belongs to, has died and it's dropped out of the picture altogether. So that was another big thing that was shown in Dr. Trapp's paper, and the reason we try to get people on treatment. Yes, sir?
Can you see those on an MRI?
No, good questions. So can we see these in an MRI? We cannot. So what nerve fiber damage looks like on an MRI is one of two things. It looks like black holes, areas where that are a white spot on one type of MRI look like a corresponding black spot. They look like moth-eaten areas. Those are areas of axonal transection. And even though we call them black holes, they're really not all black holes. They're really gray holes, darker gray holes, and black holes. The closer it is towards dark, the more nerve fibers have been cut. There have been pathological studies that show if it's kind of a light gray hole, maybe 10% of the nerve fibers have been damaged. If it's a really, really dark area, probably 90% of the nerve fibers have been damaged. The other thing that correlates with those nerve fibers being cut on MRI is atrophy or just shrinkage. There are some newer MRI techniques out there, something called diffusion tensor imaging, magnetization transfer ratios that may help us measure some of the cut nerve fibers. This is the ability to really tell what's going on within a white spot on MRI is going to be more and more important, because as we move towards neural repair, what we know is that standard MRI and the way we do it right now really doesn't measure repair. And so, if you're doing a study and you're trying to restore function, well, you'd like to see the person function better, see better, walk better. But they're going to probably want to see something on MRI also. And so there's this big push to develop these newer technologies to let you measure repair. So yeah, question? Yes.
Becoming black hole, it depends on kind of MS. It is going to be faster to turn to the black hole, or it depends on what?
So a question is, does the type of MS that we see determine whether it's going to become a black hole? No. So if we throw out the categories, and we'll come to that in just a second, but if we ignore the categories, what label we put on your multiple sclerosis, and we just take the whole world of people with multiple sclerosis, and we look at lesions that form in their brain, overall, 30% of MS lesions become black holes if we look at the whole world of people with MS. But that's a little bit misleading, because what really is happening is you have individuals who seem to be more prone to forming black holes. So in that individual, maybe 60% of their new lesions, if they're not on treatment, will become black holes. And then we've got those individuals who have much milder forms of MS who maybe none or 2% of their lesions become black holes. Ideally, again, we don't want to just sit and watch that happen. We're going to look at treatment options, but it's not so much dependent upon the type of MS. Yes?
Dr. Thorne, do the number of lesions ever decrease?
So do the number of lesions ever decrease? 5% of MS lesions, if we see them from when they first start, 5% of lesions will disappear. And that's it's very specific though. So what's happening when a lesion disappears is you've caught it brand new from when it very first popped up. And when you see a brand new MS lesion, a lot of the volume of that white spot is water, it's edema, it's swelling. And as time goes on, whether we use steroids or we just wait it out, the amount of edema, water in that white spot is going to get less. And sometimes there's so much swelling with an MS lesion that all the water part goes away and it actually disappears. If we could look at it with a microscope, it's probably, you could still see a little bit of damage, but it's below the resolution of standard MRI. So that it can happen. We have to be careful when we look at research into treatment options for MS, because you'll sometimes see slides and they'll show people with really active relapsing forms of MS, and the number of or the total volume of their white spots on their MRI before they start treatment will be this, and then they put them on a treatment, and a year later it's this. And if you're just looking at that slide at face value, you say, well, that drug's repairing the damage. It's making the white spots go away. It's probably not. What it's really doing is it's taking the active inflammation away. It's taking the water out of that active inflammation. And in most clinical trials, especially the early ones back in the 1990s, they were really selecting for people who had very active MS. They wanted people who had lots of relapses, lots of inflammation, so that they could show that their drug worked. And so those were the prime candidates to make that water part go away. That's still important. That's still a great thing. But we don't want to mislead people and make them think that the drug is actually repairing damage. So this is just a big kind of artistic representation of what's going on between the blood vessels in the brain. So on the bottom part, you've got a blood vessel. You see a little cell squeaking through there. That's a white blood cell going into the central nervous system. The white blood cells that are already there have little dots all around them. Those are chemical messengers. Those are cytokines. Those are things that the white blood cells are secreting to actually damage the myelin and damage the nerve fiber directly, or to call in other cells like something called macrophages. Macrophages are part of our immune system that go in and they chew up things. They're supposed to chew up bacteria and viruses and precancerous cells, but in multiple sclerosis, they can also go in and chew up myelin. Macrophage is a Latin word. It means big eater. Phage means eat, macro, big. So these are like little Pac-Men going in, and they're called in by those chemical messengers. You see the cell kind of squeaking through the blood vessel. That's called the blood-brain barrier. And normally the blood-brain barrier is pretty picky about what it lets get into the brain and spinal cord, and it doesn't let a lot of inflammatory cells traffic. In multiple sclerosis, your blood-brain barrier is not being quite as picky. It's letting things in that maybe it shouldn't let in. It's still not a passive process, even when you have a blood-brain barrier that's a little more leaky than it should be. What has to happen when that cell squeaks through there, it's actually like a lock and key mechanism. The white blood cell has like a key on its surface. The door, the blood-brain barrier, has the lock, and that white blood cell has to bind and open the door and go in. So some of the treatments that are out there are targeting blocking that key on the white blood cell, or maybe trying to make that door a little bit harder. When you think about drugs like interferons, beta-seron, Avonex, Xtavia, Plegridy, Rebif, these are drugs that part of what they do is they help close that door. Tysabri is a drug that actually binds to the white blood cell and doesn't let it use its key, so it does a really good job of keeping those white blood cells in the blood vessel side. Big discovery about 4 months ago. So we see the blood vessel and the cells leaking in. If you had asked researchers up until about 3 or 4 months ago whether the lymphatic system, so the lymphatic system are these channels that carry white blood cells, lymph, big part of the immune system, it was said that the lymphatic system did not go into the brain and spinal cord. Researchers at University of Virginia, again, just a few months ago, showed that it actually does. Now granted, this is in an animal model, so these are mice, and they showed that in the mouse, that the mouse's lymphatic system tracks right along with those blood vessels and goes right into the brain and spinal cord. That same research group believes very strongly that this is true in humans, so they're doing that research right now. We don't know what that means yet. Is it going to lead to new treatment options? Hopefully, but it's a big shift in the way we think about multiple sclerosis. When we go back to those Dawson's fingers, those little projections on the MRI, so why is that? Why do they project out like that? Because that's the direction the blood vessels go. So those MS lesions are tending to follow the blood vessels. Well, maybe it's not because of the blood vessel, maybe it's because of the lymphatics, because the lymphatics track along with those blood vessels too. So don't know if it's going to be a big deal, but hopefully. So shifting over to a little bit of the whys and wheres of the multiple sclerosis, the blue areas on the global map here are areas where MS is more common. So MS has always been more common in temperate climates. The further away from the equator you go, the more multiple sclerosis you see. It's true in the United States. If you look at the Atlanta metro area or you go to South Florida, our prevalence of multiple sclerosis is probably between 50 and 70 per 100,000 people. If you go to Minnesota, it's closer to 200 per 100,000 people. Some of these numbers may be getting a little blurred because we're a more mobile society, we're moving around a little bit more, but still typically you do see a little more MS as you go further north. And we'll come back to why that may be. So you'll see areas that are white on the map. These are areas where MS is just really uncommon. The continent of Africa, very unusual. So in the Atlanta metro area, for instance, us here at Shepherd Center, well, about 40% of our individuals we work with are African American. So African Americans, and really all Americans, because we are a bunch of mutts, we are a genetic mixed up group of people, we see MS across the whole spectrum of people here. True Africans, though, very unusual to see multiple sclerosis. What you'll see, though, is as you get into the northern part of Africa, Egypt, these places, and way down in South Africa, you start seeing some MS. So in the northern part of Africa, you're starting to get some European influences coming down, Spanish people, Portuguese people. South Africa, well, South Africans are Dutch, and so that's where the MS comes from there. We have a number of South African patients that we work with. Atlanta, if you're unaware, is a little hotbed for people from South Africa, and we have a number of the patients who have relatives here, and so they fly over, once or twice a year, and then we'll see them, and then they go back home to South Africa. So what are the triggers for multiple sclerosis? I'm going to start in the middle with genetics. So you got to start with the right or wrong genetics depending upon how you look at it. And that said, one of the common questions we get is, okay, I have MS, what's my child's risk of MS? What's my brother or sister's risk of MS? The risk of MS in a first degree relative is somewhere between 2.5 and 3.5%. So there is some risk, but it's not a strongly hereditary disease. There are over 60 genes that have been identified that play a role in multiple sclerosis. So to have MS, or really to have any autoimmune condition, first off, you have to be born with this set of genes. But then something else has to happen. You could be born with all of those genes and still not get multiple sclerosis. How do we know that? If we look at identical twins with MS, so if twin A has multiple sclerosis, what's the likelihood that twin B is going to get multiple sclerosis? About 30%. So that's significant, but 70% of the time twin B doesn't have MS, even though they're an exact genetic copy of twin A. So that's where these other things come in, things that you're exposed to. Infectious agents. And these are, we think a lot of these infectious agents, they probably have to hit your immune system before you're 15 years of age. And these are not weird esoteric infections. These are common things. Epstein-Barr virus, which everyone has been exposed to. If it comes into the right person at the right time, it looks like it can potentially send your immune system down the MS pathway. Human herpes virus 6, which causes roseola in children. Everyone's been exposed to human herpes virus 6. It looks like, again, it has to just hit at the right time in the right individual. There are probably other infectious agents that can do this as well, and there are two schools of thought on why these bugs may do this. We know that on their surface, some of these viruses, in their amino acids, they look a lot like myelin basic protein. So is this the part of the myelin in the central nervous system? So as this virus comes into your system, your immune system says, you know what? That's a bad bug. I'm going to kill that virus every time I see it. But over time, it starts saying, you know what, that virus kind of looks like that myelin protein. Maybe that's a virus also, and it starts cross-reacting and starts attacking the myelin in the brain and spinal cord, just as if it were that virus. There are other things in the environment that we think may play a role. Vitamin D, a lot of research in the past few years on vitamin D. Could vitamin D levels be part of this sort of north-south phenomenon that we see? So less sunlight equals lower vitamin D levels, less sunlight in Minnesota than there is here. So is that part of it? Probably, but it certainly isn't the whole answer. And I think one of the greatest examples of how this stuff, maybe not explain everything, Puerto Rico. Puerto Rico has 4,000 people with multiple sclerosis. They obviously get lots of sunshine, so they didn't read the textbook. So it may be that sunlight's part of the equation, but it may be the genetics also. Of those 60 genes, a big cluster of those genes play a role in vitamin D metabolism. So it may be the person with multiple sclerosis is just kind of behind the 8 ball and is really kind of at risk for low vitamin D levels, regardless of what their diet is and regardless of how much sunlight exposure they get. So what we've seen is that 85% of our patient population with MS has low vitamin D levels. Research is suggesting that if we correct those levels, it offers you some protection from new MRI lesions and relapses. So in the world of people with multiple sclerosis, who's most likely to have the lowest vitamin D levels of any people out there between men, women, Hispanic, black, white? Any guesses?
Women?
Women, that's correct.
African American women?
Correct. African American women have the lowest vitamin D levels of any group we've ever seen. And part of it is because the more melanin you have in your skin, the darker your skin is, the harder it is for sunlight to actually make that conversion. Sunlight takes an inactive form of vitamin D and it converts it over to an active form. The darker your skin is, the harder it is to make that conversion. But there's something else going on there as well, and it's probably genetic. So It's very, very rare for me to see an African American woman who has normal vitamin D levels. And so we check them all the time, we correct them aggressively. If you are not working with your vitamin D levels, one thing I always put in this part of the talk is don't go out and buy buckets fulls of vitamin D and start taking it by the bucket. Vitamin D is also toxic if you get too much of it. So the fat-soluble vitamins, A, D, E, and K, you don't want to just take it willy-nilly. You want to do it with some guidance. If you get too much vitamin D, you're at risk for kidney stones, which will ruin your day. So again, get your blood levels tested. Interesting research on cholesterol and HDL. Several research groups have shown that high levels of bad cholesterol seem to be associated with a higher risk of multiple sclerosis. And there's even newer research suggesting that there's a dance between vitamin D and bad cholesterol, that these things might play off of each other, that lower vitamin D levels might put you at risk for higher bad cholesterol levels. There's interesting research looking at statin drugs, the Zocor, Lipitor type drugs as potential MS therapies. The studies have been very mixed. They used very, very high doses of these drugs. It's not something we do routinely at this point, but it looks like that these lipids do play a role. Sodium intake. In animal models of MS, higher salt diets have been associated with a higher risk of MS and more aggressive attacks. And we think that probably translates into humans. So kind of keeping a watch on the processed foods and your salt intake. Body mass index. Several studies have shown that the higher your body mass index is, the higher your risk for MS is, especially in children. Where you were born, we already talked about that, north-south gradient. And then tobacco use. If you don't smoke, don't start. Smoking has been associated with a higher risk of MS and more severe relapses in people who have MS. We think that an ingredient in tobacco smoke called acrolein is the culprit here. Acrolein seems to be kind of irritating to your immune system. Hygiene hypothesis. So this goes back to the where you're born, what you do, what your immune system is doing. So what the hygiene hypothesis says is that if you live too cleanly, that if your immune system isn't kept busy doing something, you may have a higher risk of autoimmune diseases. So the hygiene hypothesis says that our immune systems were designed to do something. They were designed to protect us from bacteria, from viruses, and that if you live in an ultra clean society where everyone's using hand sanitizer and the mom or dad drops the pacifier on the floor and they boil it rather than just sticking it back in the kid's mouth, maybe that's not a good thing. My wife came across an interesting study yesterday in one of the European pediatric journals. They looked at the incidence of colds and upper respiratory infections in children, and they divided the kids into three groups. When the pacifier hit the floor, one group, parents picked it up, they boiled it, cleaned that pacifier off. The other group, the parent picked it up, just stuck it back in the kid's mouth. The third group picked the pacifier up, put it in their mouth, licked it off, stuck it in the kid's mouth. Which group had the fewest colds? Stick it in their mouth, put it in the kid's mouth, had the fewest colds. So again, the immune system was designed to do something, and again, the hygiene hypothesis says that if you don't keep it busy, then it may be more likely to turn in on itself. The decline in infectious diseases could be associated with an increasing risk of autoimmune conditions. Another kind of thought along these infections, when we think about that north-south gradient, could part of that be not only how cleanly we're living, but the types of bugs that we're actually exposed to? So here in North America, Canada, what are the things what do we typically get sick with? Viruses. We certainly get bacterial pneumonias and things like that. But typically if we get sick here, it's probably a virus. If you were living in Ecuador, Brazil, what are the things they tend to get sick with more often? Parasites. So parasites. And the way your immune system handles a virus versus handling a parasite is very different. The part of your immune system that is relatively overactive in multiple sclerosis is the part of your immune system that handles viruses. The part of your immune system that's relatively underactive is the part of your immune system that handles parasites. If you grow up in an environment where you're more likely to have a parasitic infection, Could you be at a lower risk for having multiple sclerosis? And is there any evidence of that in real life? There is. So there are several research groups, University of Wisconsin, there's a group in South America that is looking at treating multiple sclerosis by giving you a parasite. They don't want to actually give you the parasite. They don't want to give you a real tapeworm or a roundworm. What they want to do is make your body think it has a parasite. So they're actually using inactivated eggs from parasites. Kind of disgusting to think about, but you don't get the infection, but your immune system thinks it's been threatened with a parasite and it generates that immune response. The other evidence that we have that this may be a real thing is that there are several case reports of people with multiple sclerosis who have tapeworms, the real deal, an active tapeworm infection. And when their tapeworm was treated and their tapeworm was killed, their MS got worse. And so there maybe that nasty tapeworm actually was somehow toning down the immune attack of multiple sclerosis. So finishing up on this kind of speaks to your question on the types of multiple sclerosis. We've always used kind of 4 subcategories of MS, and I'm going to back up for just a second and say a term that we use commonly now is a CIS, or clinically isolated syndrome. CIS is the very first attack that a person has. So in a clinically isolated syndrome, you come in with your optic neuritis or a numb leg, and we don't know if you have multiple sclerosis at that point. We think you're at risk for multiple sclerosis. And the 2 things that help us predict whether you are going to go on and have MS or not is whether you have abnormal spots on your brain MRI and whether you have spinal fluid abnormalities or oligoclonal bands. If you have one or both of those things, you're very likely to go on and actually have multiple sclerosis. What we can't always tell you is, well, when would you have your next attack if we didn't put you on any treatment? And that we don't know, but generally we don't want to wait and find out. We would rather go ahead and get that person on treatment. So traditionally, we've talked about these 4 types of multiple sclerosis: relapsing remitting, secondary progressive, primary progressive, and progressive relapsing. These are useful. They're also probably, I think, they may be one of the biggest disservices we have done to the MS community, because people are naturally, we're dividers. We want to categorize. We want to know what box we fit in. And one of the common questions we get is, well, have I moved from one box to the next box? Have I moved from relapsing remitting to secondary progressive? And I would say, at least with those top 2, they're really not separate boxes. It's a spectrum over time. So over time, if we don't do something in MS, most people will move from this up and down, partial recovery, maybe full recovery after relapses form, to accumulation of disability and secondary progressive MS. It is not an exact science, and we don't always know when that transformation has occurred. And the other thing that's particularly challenging is this is describing the natural history of MS. This is the non-treated state of MS. A lot of people with MS are on treatment, so I think what we end up seeing in some people is we end up knocking their relapses out, but we don't stop all of their progression of disability. So when you just look at the person, they sort of look like they have a progressive form of MS, but if you took their treatment away, their relapses may come back. So the reason we have to be a little cautious with these labels, if you've heard me speak before, one of my soapboxes is you and I and the healthcare teams can talk about these gray areas and how it's challenging to use a certain label. Insurance companies don't deal in gray areas. They deal in black and white. And so if you have a label of progressive MS and your insurance company wants to play hardball with you, they can say none of these drugs are FDA approved for progressive forms of MS. So one of my mentors, Randy Shapiro, one of the grandfathers of MS care, always said in his clinic, we don't use the P word around here, the progressive word. We'll describe it, but we don't want to use that word. So one of the changes here recently is we've dropped one of these. There are actually now 3 types. We've dropped progressive relapsing from the nomenclature, which I think nobody used that term anyway. So really now we're talking about 3 subcategories of multiple sclerosis. If you looked at the whole world of people when they present with MS, most people start with relapsing remitting, and about 15% would fit into a progressive form from day 1. And then finishing up with diagnosing MS, We've come a long ways. We've come a long ways from Dr. Uthoff sticking you in a tub of warm water, or Dr. Lermite waiting to see if you got electric buzzes when you bent your neck forward. But there's one thing that hasn't changed over all of these decades. The diagnosis of MS still counts on you having dissemination of focal neurological events in time and space. So what does that mean? We're trying to demonstrate that what's causing your symptoms is multiple. There's a multiple in multiple sclerosis, and that's because there are lots of spots. So traditionally, we would wait until you had 2 attacks. You had had something that would relate to one part of your central nervous system, and then later you had an attack that related to another part. Well, we don't want to wait around now, because in between those 2 attacks, there can be a lot of stuff going on under the surface. There can be lesions that are occurring. And on average, a person with MS has 5 to 10 lesions on MRI for every 1 attack that they've had. We don't want to let that stuff go on under the surface. So even though we still come back to this dissemination in time and space, we can now use MRI to help define time and space. So if you come in with your very first attack, your clinically isolated event, and your MRI shows both old and new lesions, that's dissemination in time and space. So now, in theory, we can make the diagnosis of multiple sclerosis based upon 1 attack and 1 MRI in the right individual. So we're trying to get MS diagnosed much more quickly. There's still the need to diagnose it accurately. You don't want to stick an MS label on someone inappropriately, because in medicine, once you get a big diagnosis like multiple sclerosis, sometimes it's awfully hard to take that away, and sometimes a lot of critical thinking stops once you have that diagnosis. You know, everything that comes up, you know, you've got an ingrown toenail, that's your multiple sclerosis. You know, anything that comes up is your multiple sclerosis. So we want to make sure we get the diagnosis correctly, because we have great treatments. Some of our treatments are tougher to do than others, and there are other conditions that can mimic multiple sclerosis that are not multiple sclerosis. Thank you guys very much. I appreciate it, and thank you to the MS Foundation for sponsoring us.